Well, good afternoon. We're going to slowly ease into our afternoon session. I heard this morning another plug for working together within the registry. I just wanted to also mention the same. Please sign up. We aren't as strong as working together. We're even discussing how we can maybe get high quality imaging, working together, maybe for AI projects that are specific to focal therapy applications. That would be really great. So I think there's a lot we can do as a group. So for this afternoon session, we have 1 hour. We don't want this to be rushed. We have 3 speakers. We have a number of panelists who will stimulate the conversation. And we have Dr. Julio Pao-Sang, Michael Rothberg, Phil Stricker, Fernando Bianco. Stricker's listed twice. He must be playing on both sides. Lara Rodriguez-Sanchez and George Solomon. So let's have the panelists come up to the podium. And let's start with the first talk will be Dr. Fernando Bianco, who will speak to us about prostate cryoablation. Fernando.
Thank you, Tom, and everybody, and all of you diehards for staying in the meeting with us. So this will be just a small case to kind of take away the point that the things that we routinely do. So 65-year-old gentleman with a PSA of 7.6 and a negative DRE. Did not get the MRI images, but we got an MRI that showed a couple PIRATS3 lesions, and we did the biopsy as shown there on the screen. Came back for a Gleason 7, 3+4, and 3+3 prostate cancer. Interestingly, the tumor was located in the, you can see in the right anterior area and the mid area, mostly anterior as well. And with that, we were able to formulate a treatment plan. So in order to treat this gentleman, we go in ahead and we do it under fusion in the office setting. So we need the fusion platform, the energy platform, and again, you need a registration module, the stepper. And again, we usually do this in the office setting, and this illustrates how we treated this gentleman. We infiltrate the perineum with local anesthesia, usually lidocaine, either 1% or a diluted 2%, and we put in then the Foley catheter. And as we go, then we make sure that the prostate is in the actual place, just above that 1 number. And we go ahead and do then the deeper block. We try to block on each side of the urethra, and then do kind of like the onic maneuver with the lidocaine, so it spreads laterally, and then we kind of numb up each vascular bundle, or especially the area, like in this gentleman that we're going to treat on the right side. Make sure that the ultrasound is calibrated with the fusion device, and once this is in place, we go ahead and do the swap of the prostate. We will acquire the prostate ultrasound images coming. This can be done either in transverse or actual view. And once we have that ultrasound set up, then we will start the scanning, and that's what you see as we go through the prostate. The screen is in green, meaning that all these pictures are coming in, and then you want to capture at a rate that is smooth so you get great quality. And then the fusion really is done. We just tell the system where is the prostate, the front, the end, the apex and the base and the boundaries. And the system is the one that does the actual fusion, the core registration. So you hit that orange button, and then the prostate will show up. And this gives you the perspective on how to treat this patients, where you have your intended ablation zone, and it will also tell you where you should go in the grid and where you should place the cryoprobes so you can achieve the ablation that you desire. Of course, if you want to modify it while you're doing it, you can do that, and you can see also the prostate in both the sagittal view and transverse view. And this gives us a good perspective on the lateral boundaries, especially when the ablation starts and the whole hypoechogenicity is evident. So you can see how we nail it there. We like to see that right on the point, and then we go through the freezing and thawing process, and we have our goals set up in order to treat. And this is how we basically treated this gentleman. So, I know that there's much controversy, like this is the type of patient that you could say, well, you put him on surveillance as well, you could do that. But in our philosophy is like, if you know exactly where those tumors are, why not treat it? Because the harm associated with this is extremely low, thankfully. And that's what we've done. We made a recent analysis over 1,300 men that we have treated in this same way. It's what we define as targeted therapy, which usually means ablating less than 40% of the gland. So it's not hemiablation or hemiablation plus. And, we were looking at the differences in conversion really to surgery, radiation, or initiation of androgen deprivation, what we call the disease progression or development of METs, where we have about 65 events recorded. And we didn't see real differences between the Gleason's 3+3 and the 3+4. And then when you combine that and you see to the Gleason's 4+3, is that where you start making a slight difference. But if you were to see those curves, they look like prostatectomy curves when I was a resident doing research or a fellow. This is the sweet spot also about focal therapy, that there's an improvement in IPSS scores that is sustained over time, and that's one of the benefits to the patient. Furthermore, you're not talking about incontinence and other issues, but basically there is a great quality of life associated with this procedure, so it's not a traumatic or dramatic change in lifestyle. And the same happens even with erections without PDE5 inhibitors. You can see that there's a change, and then with PDE5 inhibitors, they go almost to the 20 score, so it's pretty good outcome. Here we show in this slide, and this QR code shows our published technique, so you can see it step by step. And one of the most intriguing aspects of this is that there will be, as we are not seeing a whole lot of predictors, we see the PSA density, however, and the absolute of PSA level, looking at this risk patrician trees, are one of the most important indicators, or maybe perhaps predictors of what's going to be the success of what we do. So this is it. Thank you very much, and I'm open to any questions.
Yes, thank you, Fernando. Great presentation. I have two questions, and I always wonder, you do a lot of this and talk to people around the country. There's this concept about the time that you hold the temperature. After you reach your diameter, is there a value of holding the temperature for a while? And if that is the case, how long?
Yeah, that's a great question, Dr. Pausan. So, we did a lot of studies in the beginning, measuring the time it takes to expand that ice ball, depending on which probes are you using. I mean, were you using EndoCare or you're using the Galil system? And for most of them, the first, I want to say 4 to 5 minutes is where you have that expansion and it holds. Now, one of the advantages of this type of treatment is that since you're not treating the entire gland, you can go full speed and full power. So we start at 100%. We don't start low and then it go crescendo. We start at 100%. And if anything, then you taper it off. But we like to hold it at least for 3 minutes. Keep that ice ball really packed, and you can see the edge of the ball, which is usually 0 degrees, and you hold it tight for at least 3 minutes. Our typical cycles last 8 minutes. We thaw now anywhere between 10 and 13 minutes. We're actually thawing passively because of the expense and sometimes the supply of helium. And then we go ahead and do another thaw, another freezing cycle at 8 minutes. And then we thaw up to the point that we can move the needles, and then we take them out, and the whole thing is passive. Yeah.
Great talk. And I was wondering, in your massive experience and long follow-up, whether your selection of patients excluded certain patients, whether it excluded extreme apical tumours, whether it excluded paraurethral tumours, and were there any nature of tissue that you were excluded as well?
Yeah, so when the tumors are close to the urethra, we use a thermocoupler, and we'll be very sensitive to the temperature around that area. And sometimes if it's very close, we'll use a warmer. I will say that we use warmers about 1 in every 15 cases or so not routinely. But we've been able to treat every tumor so far. So we don't restrict it based on that location. Aaron?
Yeah. Okay. Great. Great case. You know, having done a few cryos myself in my career, I've always done it with the urethral warmer. So that was my question. You know, as to how you feel. I mean, you haven't had any sloughing.
No, we do. We have had.
So how often do you have that, and how do you manage that?
Yeah, that's a great question. So that occurs every now and then. So we, as a routine, we try to take the Foley out, about a week later. And then the overall adverse event rate that we have associated with this patient is about 8%. And if you go there, 75% of those adverse events are related to urinary retention.
Yeah.
So 1% of the patients, we have had, out of the 1,300, we have 14 that we had to do a TURP.
Yeah.
Okay? But most of the time when they have some of that sloughing, it doesn't bother them. They tell you, and then it goes away within.
Yeah.
Within.
I guess the question is, why not put the warmer in? I mean,
why not use it?
Yeah, I mean, if you've ever dealt with it, and I'm sure you have, and I've dealt with it in the years past before we had a great warming system, it's difficult. You know, you have intermittent catheterization, prolonged catheterization, TUR, et cetera, et cetera. Why not?
Well, often what you see when you're doing this is that the urethra gets pushed to the opposite side, so it's not even close. I mean, and even if the tumor is closed, then you want to, take it completely, because sometimes you have the catheter in the middle. But I guess that we have started that way. It hasn't become a big enough problem to make us change so far.
Okay.
But, many people use it like you do all the time. I mean, Dr. Shanti uses a warmer all the time.
Yeah.
And it's good practice. I'm not saying it's not, but I tell you, it's another, just getting it in. I guess it adds a little bit of time.
Well, it also seems like you're treating more primary cancers than you are salvage cases. So maybe in the salvage cases, it clearly has a role, maybe not in the primary untreated cases. Yeah. Great.
Hi, thanks. Great presentation. Could you elaborate on how, if at all, your treatment planning has changed? I mean, I noticed your sort of the way that you marginated with your planning around your tumor.
Yeah.
I guess, do you feel that is limited at all by the software? Are you able to adjust that? And has that sort of planning in your margin changed over time as these 1,300 cases have been performed?
Yeah, certainly has changed. And as we migrated to transperineal biopsies, because we started back in 2013, really, that's where we start having more change. So since 2017, we haven't done a transrectal biopsy, right? So now we use the information of the positive course, and we also use the information that's driven by the negative course, and that helps us set up the boundaries of where we want to go. And of course, then the natural boundaries, the lateral boundaries of the prostate, we try to stop right there. So then we measure, based on, on the estimates of the ice balls, how that's going to go. And then depending on the cryo machine that we're using, or in Miami, we use mostly V-probes, so you can measure the length. And all that is done before we take the patient to the procedure. So all that is done when we plan the procedure. So the day of the procedure, really what we're doing is executing the case. We don't worry about the planning. If we have to change something on the fly, we'll do it, but it happens less often than, it really doesn't happen that much.
And a quick follow-up. So, in your the post-treatment biopsy, there's typically 4 cause, and then when they are done, are they targeted only or targeted plus a template?
So great point. Okay, so we were doing it, encouraging all of our patients to have these biopsies routinely, and we did this up to 2019, where we did an analysis where we have about 70% of our patients up to that point that had a biopsy. And we noticed that if you apply the PIRATs to the untreated prostate and that was a 1 or a 2, and you did not have contrast enhancement, really, the positivity of that biopsy was about 4%. Now we have a big series that we're going to be submitting soon, with a lot of these patients. And that's where we said, for those, we give them the alternative. We said, if you want to be very, very intense, you would get another biopsy. Otherwise, if the PSA is non-trending and the MRI is essentially negative, we just watch them. And after that point, the other amendment we had done is that we want to do an MRI at least at year 5 for everybody, so we're encouraging that since we have many. And in between time is for costs. It depends on the PSA fluctuation.
Great presentation, Wei Pintan, NYU. I wanted to get your thoughts on whether you think the type of biopsy actually matters after cryoablation. Because usually when we freeze for cryo, we freeze based on the length of the prostate, right? So you're going from base to apex. So technically, you shouldn't recur on the base or the apex if you didn't leave residual tissue there. But what happens is that the freeze going down, if you don't freeze enough, you may get recurrence on the AP axis of it. So if you're only doing transperineal biopsy, you may miss that and you may not pick that up. Whereas if you come from the rectum, you have a higher tendency to pick that up. And full disclosure, I only do transperineal biopsy.
I think that how you do the biopsy matters, and the information that you get from your pathology matters as well. We've been working with a pathologist out of PathNet that gives you the actual amount of tumor that's in that core and where it is. So now we can map that to the fusion system and have an idea of, the cancer distribution. One of the advantages of a transperineal biopsy is that you move away from this concept base, mid, apex, right? You're often biopsying 2 zones at the time, and you understand then the tract. And yes, you can measure it based on the length of the prostate. If it's not going to really harm the urethra or the bundles, then you can take more tissue if you wanted to. All right.
Okay, thank you.